Hi guys, I'm Tamara from the Sepsis department. Just going to talk a little bit about sepsis and why do we care so much about it. You guys just watched that video, so you see that sepsis can affect more than just our frail elderly patients. It can affect young people, like in the video, or actually what started the sepsis campaign a few years back was a 9-year-old little boy was from New York, was playing basketball, and he fell and scraped his elbow. Mom didn't really think much of it. A few days later, started running a fever, wasn't feeling well. By the time they brought him in, he was in septic shock and he died. And there wasn't a lot of recognition at that time. So the parents really stressed that as healthcare workers, we should be better at recognizing sepsis and treating it. So they came out with a sepsis core measure, and that's what we're going to talk about today, and what the requirements are and what it means to us as nurses. So let's start from the beginning. So what is sepsis? It's that overwhelming response to an infection. It's more than just that localized response that we get to just a simple infection like a pneumonia. It's a systemic response, and really that's the problem. That's what leads us to tissue damage, organ failure, and sometimes death. It's one of the leading costs to U.S. hospitals, and one of the leading causes of death around the nation. So that's really why we have to kind of talk about it and focus on it a little bit. We built these building blocks so we could know what was CMS's requirements and what an easy one look on what we need to do. So if you guys in your units, they should have these at the nurses station. So we'll just talk about it quick. So if you look at the yellow column, it's that SIRS column. So SIRS is that systemic inflammatory response. So something's happening, our body is kicking in, doing things. So if you look at them, it's nothing crazy. Lower high temp, heart rate greater than 90, respiratory rate greater than 20, and a white count less than 4 or greater than 12. And you guys have probably heard me say this before, but don't forget the lows. Sometimes we kind of skim over that and think, oh, a white count of 3-5, we're golden. Maybe not if it meets all of the other steps, or even the temp isn't crazy for a high temp, but then if you look at the low temp, 96.8, sometimes we might, again, brush that off and not think it's important. So for sepsis, you need to have 2 of the SIRS criteria, and then you also, if you move on to that light orange column, you need to have a suspected source of infection. So really be thinking about what your patient's here for. What do they have something that could cause an infection? Whether that's a pneumonia, a UTI, a wound, maybe they have an ulcer, maybe they just had surgery, maybe there's just so many things you could think of that could be a source of infection. So if you partner that with 2 SIRS and a suspected source, you could be hitting the sepsis mark. When you move into the darker orange, that's when really the time starts to tick. So you have to have sepsis, and you have to have a sign of organ dysfunction that's new for the patient. So not that you have to memorize all of these, but just again, keep in mind that it's an organ dysfunction that's new for the patient. So a lactate greater than 2, an INR greater than 1.5 without them being uncoumated, a PTT greater than 60, a platelet count less than 100,000, and they're not chronic thrombocytopenia or a chemo patient, a bilirubin greater than 2, and they're not a cirrhosis patient, creatinine greater than 2, they're not a dialysis patient, or it's greater than what their normal baseline is. So, or no urine output. And then the blood pressure parameters are systolic blood pressure less than 90 or a MAP less than 65. And again, that's not normal for the patient. So some patients might run low and that's their norm, but then it has to be documented that that's their normal. And then for respiratory failure, the patient either needs to be on BiPAP, CPAP, or intubated. So an example, just to kind of think about it a little bit, is so if our kidney dialysis patient comes over and has a creatinine of 4, and they're normally like 2.2, 2.3, something like that, and the doctor documents that this is higher than normal, then we can say that that's a problem for this patient that's caused by the infection. Now, if I came in with no history of kidney problems with a creatinine of 2.7, 2.5, then that would be a sign of organ dysfunction for me. So once you hit all of these criteria, so 2 SIRS, a suspected source, and a sign of organ dysfunction, then we have 3 hours to get a few things done. And we'll talk about those in a little bit. I just want to talk about what then creates septic shock. So you have to give fluids for severe sepsis. And if they still are persistently hypotensive after fluid resuscitation, or their initial lactate is greater than 4, then they meet that septic shock criteria. As we move on here, we'll talk a little bit more about those interventions and what we need to do. Again, just remember with that septic shock, sometimes we think that if their blood pressure is normal, that they're not in septic shock. But if that lactate's greater than 4 from the get-go, then they do meet the septic shock criteria, even if that blood pressure is normal. And just really think about septic shock, that there's that critical reduction in the patient's tissue perfusion. So what does all this mean to you guys as nurses? Really, it's early recognition. We need to really be thinking about could they be septic, and be able to recognize that quickly. I feel like when we come into the ER and we're in full-blown septic shock, we're picking that up pretty quickly. It's when we're up on the floor and maybe those patients are having subtle changes that sometimes it takes a little bit more to recognize. So really be thinking about that first. And if you think about this, that every hour we delay care, their risk of mortality goes up 8%. That's pretty huge. So we really need to do our part in recognizing it. So in order to help us with that, eCare does have that severe sepsis St. John's tool. So you guys have probably seen that. What it does is it runs in the background of all of our patients here over at St. Joe's in the ER, and it's looking for patients that meet criteria. So it looks for 2 SIRS and a sign of organ dysfunction. It can't pick up a source of infection, so that's kind of up to us, but it will pop up the 2 SIRS and an organ dysfunction. And when you guys see that, it will pop up on the screen so you know what has triggered it. In order for this to work well, documenting our vitals soon as we can is pretty key. I know sometimes that doesn't really happen all the time, but if those vitals are in your pocket for your entire shift, then the system can't pick that up. So do the best you can with that. Once the patient does meet criteria, it does go to in the ER, and I think on labor and delivery it pops up on your grease board with an icon, but on the floors it will pop up onto your task list. It'll fire and saying your patient has a sepsis alert, and it does pop up to the charge nurse, but it does not go to the physician. So just keep that in mind. So if you guys see an alert, it's going to prompt you to do a full new set of vitals, perform a quick assessment, and then let the patients know, or the provider, I'm sorry, know that their patient's popping a sepsis alert. In the ER, you can show them, they might see that icon before you guys do. But on the floor, especially like I said, that the providers don't see those alerts, so your job is to let them know that they popped a sepsis alert. And this is what it looks like when you see it. So down on the bottom on this patient, you can see that his white count was elevated, his respiratory rate was high, and then he had a MAP less than 65. So in this case, if it was my patient and the charge nurse said, hey, your patient came and popped a sepsis alert, I would go back in, get a new set of vitals, take a look at my patient, and then you have to really think about, are they already being treated for sepsis? Are they comfort care? things like that, where if they're already being treated for sepsis and the doc has already ordered a sepsis protocol, then you're good to go. If it's a patient with pneumonia, now they're popping it, or some other reason that they're admitted and now they're popping a severe sepsis alert, it is really important to let that provider know so that they can do the workup. They can order a sepsis order set right then and there, so you can get labs and all of those things. So just be thinking about that. And it does pop up on the next. This is what you guys will see on your form, so you can document it. Tells you again what you see, and then on the bottom there's a place to document your vitals, who you've talked to, are they already on a sepsis protocol, and then if you've received any orders. So the next part is just what CMS requires. So once we meet severe sepsis criteria, we need to measure an initial lactate level. We need to get blood cultures ×2 prior to starting our antibiotics. Then we need to start a broad spectrum antibiotic. Before, CMS used to have some requirements of starting a monotherapy antibiotic or a combination of 2 antibiotics, but now it's only required that we start an antibiotic, and that needs to be started either 24 hours prior to meeting severe sepsis criteria or 3 hours after. So if you're meeting, we need to get that hung. And then the next part is about fluids. We're going to talk about that for a little bit. So right now, if your patient meets criteria and they either have a lactate greater than 4 or they're hypotensive, so systolic less than 90 or MAP less than 65, we need to give them 30 mils per kilo of fluid. So you guys, that's a lot of fluid. So if you have a 100-kilo patient, they need 3 liters of fluid. Doesn't mean you have to slam it all in, but it needs to be started within 3 hours of meeting that criteria. Before, CMS really didn't have any exceptions to that rule other than patients with an LVAD. Now, they have recognized that some patients might not do well with too much fluids. So they're talking about our advanced or end-stage heart failure patients or our end-stage renal patients. So in order for the patient not to need 30 mils per kilo, the provider must document that it would be harmful, that they meet the above criteria of advanced end-stage heart failure or renal failure, and then what fluids they think that the patient could handle in place of that 30 mils per kilo. So maybe they'll say this patient is end-stage renal failure. I think 30 mils per kilo would be detrimental. I'm going to give him 500 or 1,000 and see how the patient does. Something like that. So one more thing about fluids is, there's a couple more things. So fluids must be crystalloid fluids. They must be ran greater than 125 mils per hour. So sometimes you'll see an order for like, give 500, and then run fluids at 150. So that would meet the goal as long as we give all of the fluid they need. Another thing is, so sometimes we have very large patients that come in, so they might require 4 and 5 liters of fluid if we went 30 per kilo. So if the doc documents that they are treating the patient by their ideal body weight, then we could give them a little bit less. Again, that requires the provider documenting that their BMI is high and that they are treating them for ideal body weight. After fluids, we also need to repeat our lactate if it's greater than 2. If they're ordered yes for sepsis, it will automatically fire a redraw. So just for you guys to know, be watching for that second lactate if the first one was greater than 2. If the doc orders no for sepsis, it won't fire that. So you may have to ask your provider, do you want to repeat if that first one comes back greater than 2? And then if they're still persistently hypotensive, we need to start a vasopressor. A lot of times they're using Levophed, sometimes norepi or phenylephrine. Typically not a lot of use of dopamine because that's going to elevate their heart rate and they might already be tachy. So that's what we're seeing. And then not listed on here, the providers then need to document a reassessment. Lindsay and I up in the sepsis department do try to look at sepsis patients as we're able to. And if we are able to, we'll do a feedback form. We try to send that out to your nurse managers, your educators. And sometimes if we know who is taking care of that patient, we'll try to send it to you too. And this just shows, did we meet or did we not meet? And on the bottom, it will say some opportunities. So sometimes what we see is maybe that broad spectrum antibiotic was started greater than 3 hours. Once in a while, we miss getting the lactate altogether or miss that redraw if it was greater than 2. And then for fluids, sometimes we're not scanning all our bags, so make sure that you do that. And I mean, those are the big things that we see as opportunities. So just going to do one quick case study and then we'll be done with sepsis. So there was a 74-year-old male who recently was here for a small bowel obstruction. He was here, was discharged to the nursing home, had an indwelling Foley, and he presented with some blood in the catheter causing some retention. So EMS was originally called over to the nursing home, and when they got there, the patient was alert and oriented. His heart rate was 104, his respiratory rate was 21, temp was 99.3, and his pulse ox was 98%, blood pressure was normal. But EMS does report to the ER that the nurse at the nursing home said he seemed off earlier today. That's kind of a key thing to think about. So when you look at these vitals, what do you guys think about that? I mean, his heart rate's greater than 90, respiratory rate's greater than 20, but right now we don't really see any organ dysfunction, but he might have a possible source of infection with that Foley. So the physician comes in and sees him. They switch out the Foley. He has 1,100 mils of urine out. They flush him for the blood, and it does clear up. His urine's not grossly infected. Lab work was really unremarkable. He didn't have a white count. His creatinine was stable. Yeah, maybe there was a little bit of a UTI. His lactate was within normal limits. But the doc was kind of wondering, like, what really was he off about? So he did call over to the nursing home, but that nurse had already left, and the night nurse wasn't really sure what they meant by him being off because he didn't take care of the patient when he came over. So the plan was the patient really didn't want to be admitted, but the doc wanted him to be observed for a little bit. He did give him a dose of antibiotics for that possible UTI, wanted to observe a little, and then they were planning to arrange for some antibiotics at the nursing home. So the patient fell asleep. Things got busy in the ER. When he woke up, he was now adamant that he was going to go back. He didn't want to be here. He slept. He felt better. So he was really getting ready for discharge. They had already pulled the IV. They called the ambulance to take him back. But as they were waiting for the ambulance, I think they had gotten called out on a couple other calls. The patient kind of became confused again, a little more agitated. He was trying to crawl out of bed, things like that. So the nurse did get a repeat vitals. Now his heart rate was in the 130s. His respiratory rate was 24. He was spiking a temp at 101.7, and his blood pressure dipped to 86/45. So if you look at that, now he actually has 3 SIRS and a source of organ dysfunction with that low blood pressure. So immediately they thought something was wrong. They redrew some labs. They put 2 new IVs in. They gave him some fluids because this was before he got the full 30 mils. His lactate now came back at 3.4, so not septic shock criteria, but still high. White count was now 14. So he got about 2.5 liters. They ended up having to start some pressors on him because after the fluids, he was still low. Broadened his antibiotics. he was admitted to the ICU. So follow up, he had E. coli in his urine, and his blood cultures did come back positive. So in this case, he did spend a few days in the hospital and was eventually discharged back to the nursing home. But what I really want you guys to think about is the fact that the nursing home staff thought something was off, ER staff thought something wasn't quite right. They observed him, they reassessed, and they got treatment started quickly when he did start to decompensate, and the patient ended up doing well. So that was just a good example of us taking good care of our patients. And I mean, we could have just sent him right back, and then maybe he would have came back in a worse state and wouldn't have done well. So good job to the staff for taking good care of this patient. I'm not sure if you guys have any questions. If you do, let Kelly know, or you guys can always give me a call up in the sepsis department. And that's all I have for you on sepsis. Hope you guys have a good day.